everyone, and welcome to the second of our bite-sized talks. I'm Charlotte.
And I'm Juliana.
And we'll be saying a bit about our findings from the study that we carried out as part of the Tackling Inequalities and Discrimination Experiences Among Healthcare Staff, or TIDES project. And this particular study aimed to understand how healthcare professionals made decisions about whether or not to take up the COVID vaccine. So first of all, Juliana is going to run through the key messages from our study.
Thanks, Charlotte. So the decision to take up an offer of a COVID-19 vaccine was neither simple or without burden for any of our participants. And that decision process seemed to be influenced by a number of different factors, which were sometimes competing factors. And also that the perceptions and/or the lived experience of discrimination at an institutional or structural level seem to play a key role in the decision-making around COVID-19 vaccines. But this was particularly evident in our racial and ethnic minority healthcare staff. But how did these key messages come about? What was the actual study about?
Thanks, Juliana. So we spoke to 25 healthcare professionals, including both nursing and midwifery professionals. So that included students, healthcare assistants, qualified nurses, as well as senior management. And that happened between October 2020 and January 2021. So just as we were moving into the second phase of the pandemic, and obviously just before and at the start of the rollout of the vaccine to priority groups. And so we asked them in interviews about their experiences since the outbreak, including some specific questions on their thoughts about vaccination. So in general, people were divided into those who would immediately accept if and when offered, those who were undecided or would delay their decision, and a small number who were sure that they would decline. And making the decision was really a personal process of weighing up the risks of harm from being vaccinated against any potential benefits for themselves and others. And for everyone we spoke to, there were lots of different but related things that went into that decision. Some were common to people in the general population, and some were more specific to healthcare professionals. But we also heard ways in which the decision-making process was weighted more heavily towards hesitancy for racially minoritized staff groups. So regardless of racial or ethnic group, staff who were inclined to accept, so whether that was immediately or they were thinking about delaying but likely to accept eventually, they really stressed the benefits of vaccination, which obviously included protection from COVID, not spreading it to others at home and at work, supporting a wider effort to tackle the pandemic, and of course wanting to return to normality as soon as possible. On the other hand, those who declined or who were still very sort of uncertain highlighted fears of harm, really linked to not trusting how the vaccine was produced, about fast tracking, and a lack of longer term evidence. And this really played into concerns about potential side effects, including both immediate or possible long-term effects. And these worries were relevant to people with existing health conditions who, under normal circumstances, wouldn't normally take up other vaccines, so for example, as flu, to people who were worried that they might react to the vaccine because of an issue that they weren't aware of yet. And it also included people who were just cautious based on past problems with drugs, such as with the thalidomide. For racial and ethnic minority groups, this lack of trust was really exacerbated by the impact of past and contemporary injustices in drug development and testing, lack of representation within drug trials, and also for some a mistrust in the government agenda. And as we've heard, on the news and on social media, some staff indicated that religious and ethical concerns about the vaccine may be a barrier, and that this may disproportionately affect some racial and ethnic minority groups. And also, that also linked to issues around information and misinformation. So lack of access to clear and trustworthy information about the vaccine, as well as to exposure to misinformation, particularly via social media, was also highlighted as a barrier for all staff. But again, for racial and ethnic minority staff groups, interviewees highlighted issues about the legitimacy, accessibility and sensitivity of vaccine messaging, and really a lack of communication that directly addressed the concerns that may be more common in some groups. So for example, around the vaccine composition, its impact on fertility, but also social norms around vaccination. So we also identified particular concerns about the extent to which staff would be pressured or even mandated to take up the vaccine at work. And there were fears about the wider potential repercussions of not taking it up. So, for example, in terms of being prevented from travelling to work to see family abroad, but also repercussions at work in terms of potentially losing their job or losing work hours or being moved away from patient-facing roles. And again, participants felt that these concerns would be greater for racially minoritized staff groups who may experience greater suspicion and fears around institutional pressures to be vaccinated, and that this was linked to mistrust grounded in experiences of discrimination both within and outside of the workplace. So there were some factors linked to hesitancy that were common across staff from different racial and ethnic groups, but that may have disproportionately affected racially and ethnically minoritized staff, such as religious concerns. And there were some factors linked to hesitancy or decline that were weighted, as I said, more heavily for racial and ethnic minority groups, such as fear, mistrust, suspicion and lack of access to appropriate messaging. And it was clear that the underlying driver for greater hesitancy linked to these concerns was both expectations of and experiences of unfair treatment, discrimination from authorities, pharmaceutical companies, as well as the health service.
So what do all these results mean if you're a healthcare worker? Well, one of the key things from the paper that we've learned that concerns or hesitancy about COVID-19 vaccines are not unusual, and actually the individual decisions that a healthcare worker might make about the vaccines will be and can be affected by several different factors. And these also might include broader issues that are affecting society at large. So it's really important about accessing clear information from trustworthy and informed sources that also actually offer you an opportunity to address your own specific or particular concerns. But what if you're a manager or a senior leader? What are the implications? What would the results of the study mean for you? Well, one of the key things here is that we know that vaccine hesitancy, or indeed concerns around vaccines, can be found across different groups in society and be found across different groups in your organisation. And that's irrespective of one's social or demographic background. But we know when we're focusing on racial and ethnic minority staff, we know that vaccine concerns and hesitancy are more likely to be quite closely linked to their own lived experiences and wider issues around discrimination. So as a manager or senior leader, I think it'd be very important to proactively seek to identify or understand what might be the individual concerns around vaccine uptake. And perhaps more importantly, to also offer very clear, targeted and factually based information and reassurances where required to help staff reach or make balanced and informed decisions around the vaccine. Finally, what could our findings mean for policymakers? Broadly, we should be considering offering much more targeted and nuanced approaches to reducing COVID-19 related health inequalities. And our current models for understanding vaccine hesitancy and concerns must be framed within a broader contextual framework that acknowledges the direct health impacts of discrimination at an individual and community level. It's clear, as we've seen, that perceptions of discrimination in society can perpetuate health inequalities in minoritised and marginalised groups. So this really requires much more coordinated efforts to address this, and this should actually be considered a health priority.
The paper is fully available online. Both the published version and also a summary version is there. And you can see more about the TIDE study on our website. You can let us know your thoughts using the Have Your Say function, and you can get in touch by email and by social media. Thank you so much for listening.